Support and Training. And this is being done by the New York Children's State Plan Amendment SPA Service by Service Overview Series. My name is Geraldine Jerry Burton, and I am with CTAC. Our presenters for today are Angela Keller, who is the Director of the Bureau of Children's Programs Design, Policy, and Planning, Division of Managed Care, New York State Office of Mental Health; Meredith Ray LeBlanc, Deputy Director, Division of Integrated Community Services for Children and Families, New York State Office of Mental Health; and Heather Lane, LMSW, OMH Family and Youth Peer Coordinator, New York State Office of Mental Health. So before we really get into our webinar, we have some housekeeping and logistics that we need to go over. The WebEx chat functionality is for questions and answers. The slides are posted on the MCTAT website, and a recording will be available soon, usually less than a week after this webinar. Questions not answered today will be reviewed and incorporated into future training and resources. And a reminder, information and timelines are current as of the date of the presentation. Content presented is summary and discussion of the draft SPA manual currently available online. And please refer to the manual for further detailed definitions, references, and other useful information. So our goal for today is to review the key information from the SPA manual, add context and clarity whenever possible, to generate and answer questions, and to help inform service providers about the decision-making process about obtaining SPA designation. The designation process will be finalized and announced soon. A presentation and opportunity for designation-specific questions will also be offered. So at this time, I'm going to turn it over to our presenters.
Okay, good afternoon. This is Angela Keller from the Office of Mental Health. What we hope to achieve in this hour-long webinar is to do a refresher on the Children's System Transformation and the State Plan Amendment, talk specifically about family peer support and youth peer support and training, and review upcoming training and resources, and have some opportunity for question and answer. I do want to note that we do not have OASAS state staff on the phone today, so as people do ask questions related to the OASAS peer requirements, we will have to take those questions and release a question and answer back to folks. But please do ask those questions so that we can get them to the right people. So for the refresher on our timeline, next slide, is Children's Health Home is still anticipated to start on October 1 of this year. The new state plan services will begin statewide in January of 2017. And in July of 2017, for New York City, Long Island, and Westchester County, we will transition the existing behavioral health services, the new SPA services, the home and community-based services, and the voluntary foster care population to managed care. Those same transitions will occur for the rest of the state in January of 2018. So we have a little bit of an update for regarding the state plan. Next slide, please. So the provider manual was released on March 9th, 2016, and we would anticipate that we will be releasing another version of that in the coming month or so, so be on the lookout for that. The 6 services that we're proposing for CMS's review and approval are crisis intervention, other licensed practitioner, community psychiatric supports and treatment, psychosocial rehabilitation, family peer support services, and youth peer support and training services. Again, as we've mentioned, we will be talking about a state plan designation and application phase We're in the final development and revision of that, and we will have a separate webinar as we get closer to that release. The draft SPA rates will be made public, we hope around the same time of the application release. So what is it that we're trying to achieve with these new state plan services? What we really want to do is make sure that we're identifying needs earlier in a child's life when they're experiencing challenges, that the array of services through the new state plan additions will help to maintain children at home in their community, and that we're really, by addressing needs sooner, preventing the need for longer-term and more expensive services, and certainly increasing the delivery of those services following a trauma-informed care approach. So for those of you maybe that have not had a chance to read the SPA provider manual, it is split up in the sections that are detailed on this slide. So it gives you a definition of each specific service, where can the service be delivered, what is the admission and discharge criteria or medical necessity criteria, any limitations, exclusions, and then most importantly, I think, for most folks on the phone, is what are the agency supervisor and practitioner qualifications, including required and recommended training. That manual is available at mctech.org under their resource section, and it's also on the Children's Managed Care website, which is, I believe, listed on the either last slide or the second to last slide. So just a few things to mention about the state Medicaid services that we are proposing. They will be, next slide please. They will be available to all Medicaid eligible children under the age of 21 who meet the medical necessity criteria. We expect that they would be delivered in a culturally competent manner and be trauma informed. It allows for the interventions and services to be delivered in community-based settings where children and families live and work and socialize, and that it would really bolster the need for more intense services. The authority for these new services under the state Medicaid plan fall under the early periodic screening, diagnosis, and treatment benefits. Other key points on the SPA services is where I think in the past, as new services have been implemented in the state plan, for the most part out of certainly the Office of Mental Health and Office of Alcoholism and Substance Abuse Services, typically those would be released as programs and with regulations and all sorts of things. These are really standalone services. They are not programs. We would expect that as these services are provided to children, that communication and coordination with their family, their caregiver, and or their legal guardian happens. And with all the children that we serve, they're involved with multiple child serving systems, and that coordination also needs to occur. When these SPA services are launched, they will initially be billed in the fee-for-service system and then be transitioned to Medicaid managed care in July of 2017 and January of 2018. Once we complete the designation process for these SPA services, providers can begin contracting with the Medicaid managed care plans. We would anticipate designation is going to occur between August and October, and that starting in January would be when the kind of contracting activities would occur. Just to point out with medical necessity, there is a general definition that the state follows, that it really corrects or ameliorates conditions found through screenings or evaluations. And then whatever is found is addressed through treatment or other services. Each state plan service that we're proposing is going to have criteria for admission, continued stay, and discharge, and more to come on that very soon. So right now I'm going to turn this over to Heather Lane to talk more specifically about the family peer support services, and then Meredith Ray Labatt will talk about the youth peer support services.
Good afternoon, everyone. This is Heather Lane. I work for the Office of Mental Health in the capacity of the statewide Family and Youth Peer Coordinator. Today I have the great pleasure of walking you through Family Peer Support, which is one of the 6 state plan services. Family Peer and Youth Peer Support are an array of formal and informal services and supports provided by peers who are individuals with lived experience. Family peer support services will be provided by a credentialed family peer advocate who has lived experience parenting a child with behavioral health challenges. This service is designed to support parents and caregivers for the benefit of the child. Youth peer support and training will be provided by a credentialed youth peer advocate who has self-identified as a consumer recipient of behavioral health services, special education services, or foster care. This service is designed to support the identified youth. As with the other SPA services, we really have expanded the definition of family, and family is a unit of people residing together with significant attachment to the child or youth. It includes both adults and children, with adults taking on the parenting, caregiving for the children, even if the individual is living outside of the home. Family is broadly defined and can include families created through birth, foster care, adoption, or self-created unit. So for family peer support services, you can advance the slide, please. Family peer support services, again, is an array of formal and informal services and supports provided to families caring for or raising a child who's experienced social, emotional, substance use, and or behavioral health challenges in their home, their school, their placement, or community. Family peer support provides a structured, strength-based relationship between a credentialed family peer advocate and the family for the benefit of the child. Could advance the slide, please. The services under the umbrella of family peer support include engagement, bridging, and transition support, self-advocacy, self-efficacy, and empowerment, parent skill development, community connections, and natural supports. For those of you on the phone who are OMH providers currently, please note that in the current definition, there is a service called Outreach, Information, and Promoting Family-Driven Practice. That actually has been omitted from this particular service as we submit it to CMS, because the activities are not directly related to the youth and therefore are not Medicaid billable. For the services, and we're going to go through each one of the services categories underneath family peer support, for the next 4 slides, we'll highlight some of the activities that are included underneath each one of these service categories. But before we begin, I think it's important to emphasize that all of these activities, the family peer advocate works directly with the family and to support the family and assist the family in their role as a caregiver for an identified child or youth. So the work that's being done through this service is with the family for that identified youth. One of the categories is engagement, bridging, and transition support. Some of the activities highlighted are based on the strengths and needs of the youth and family, connect them with appropriate services and supports, serve as a bridger between families and service providers, supporting a productive, respectful partnership by assisting the families to express their strengths, needs, and goals, address any concrete or subjective barriers that may prevent full participation in services, and support and assist families during stages of transitions. For example, when the child is in placement coming back home, if the child is in crisis, or when they're transitioning between service systems. And once again, these are just highlights. More examples can be found in the provider manual. For self-advocacy, self-efficacy, and empowerment, it's assisting families to advocate on behalf of themselves and their child to promote shared decision-making, to empower families to express their fears, expectations, and anxieties to promote positive shared decision-making, and to assist families to frame questions and to ask providers. So it's really promoting that competency within that particular family and that self-advocacy within that particular family. The next category is parent skill development. Supporting families in the role is their child's advocate by modeling and coaching, and this is done a lot in family peer support. Assisting the family and helping the family learn and practice strategies to support their child's positive behavior. To assist the family in implementing strategies recommended by clinicians and provide individual or group parent skill development related to the child's behavioral or medical health needs. And the last category is community connections and natural supports. Within this category, we're highlighting enhancing the quality of life by integrating and supporting families in their own communities, helping the family to rediscover and reconnect natural supports already present in their lives, to utilize the family's knowledge of their community in developing new supportive relationships, and to help the family identify and become involved in leisure and recreational activities in their community. The qualifications for family peer support, a family peer advocate needs to be a credentialed family peer advocate. A family peer advocate can also have a provisional family peer credential. Please note that within 24 months of that provisional credential, they would have to obtain their full credential. Or a family peer advocate could be a credentialed recovery peer advocate with a family specialty, and that's really specific to the OASIS system. More about the credentialing itself for the family peer advocates can be found on the Families Together website, and for the Certified Recovery Peer Advocate, currently there is an RFP out to identify an organization for the training of the Certified Recovery Peer Advocate, and that can be found on the OASIS website. To obtain the OMH Provisional Family Peer Credential, a family peer advocate must have that lived experience that we talked about, must have a high school diploma or equivalent credential, and that can be waived by New York State if the person has demonstrated competencies and has relevant life experience, and we are submitting that to CMS. We'll see how that goes, but we really want to kind of push that a little bit because currently that's we do have that within our credential. To obtain a provisional credential, a family peer advocate must complete level 1 of the Parent Empowerment Program training, and that is a online training that we will be launching sometime next year, or approved comparable training. They must have 2 letters of reference attesting to the proficiency and suitability for the role of a family peer advocate, and they must agree to practice according to the Family Peer Advocate Code of Ethics. Once again, the provisional credential is valid for 18 months while completing level 2 of the training, and level 2 is comprised of both online and in-person training and acquiring the 1,000 hours of documented experience as a family peer advocate. For the full OMH Family Peer Advocate credential to be eligible, a family peer advocate must have that lived experience, must have the high school diploma or equivalent that can be waived, depending on the competencies, must complete Level 1 and Level 2 of the Family Peer Advocate Core Training, and must have 3 letters of reference attesting to the proficiency and suitability of the role of the FPA, and 1,000 hours of providing family peer support services. There is, once a family peer advocate is credentialed, there is 20 hours of continuing education every 2 years that must be maintained in order to renew the renew the credential. I should know that OMH, for those of you who are funded through OMH, you're probably pretty familiar with the credential. We anticipate, as I said, next year to launch Level 1 and Level 2 of the training, which really is adapted from the current PEP training with some enhancement. I would, for the OMH providers out there who have family peer advocates on your staff, I would really encourage you to get those staff credentialed. There is currently a vouchering process to offset the cost of the training and the initial credential application for the family peer advocate. And also for those providers in New York City, there's also an opportunity to pursue funding for agencies who may not receive OMH funding but do have family peer advocates on their staff through the New York City Thrive project. And I'd refer you to the Families Together website that has information not only about the credentialing process but also the vouchering process and the New York City Thrive opportunity. For OASIS, for the Certified Recovery Peer Advocate with a family specialty, a advocate needs to be 18 years of age. They must have that lived experience as a family member impacted by a youth with substance use disorders. They must have a high school diploma or equivalent degree. They must have 46 hours of training in advocacy, mentoring, and education, recovery and wellness, support and ethical responsibilities, 1,000 hours of documented related work experience, and it could be 500 hours of related work experience if they have a bachelor's or a KSAC or a KSAC-T, or completed the 30 hours of recovery coach training. Now, within that 1,000 hours, 16 hours have to be in the area of a family specialty, which is noted below. They need to have 25 hours of supervision. They need to pass, they need a passing score on the peer advocate exam or other exam by an OASIS designated certified body. They they need 2 letters of recommendation and 20 hours of continuing education every 2 years. So supervisor qualifications for a family peer advocate. There should be 1 hour of supervision for every 40 hours of family peer support, and there is an option to have a separate administrative supervisor. For a family peer advocate supervisor for OMH, it could be a family peer advocate with a minimum of 4 years providing family peer support services, including 1 of which needs to be a year in which that family peer advocate is credentialed, or a family peer advocate could be supervised by a mental health professional with training in family peer support and the role of family peer advocates. And the family peer support program moves to transition to supervision to an experienced FPA, family peer advocate. The qualifications for the Certified Recovery Advocate is a Certified Alcohol and Substance Abuse Counselor, KSAC, working within an OASIS certified program, and they must be provided by an organization documented and qualified to provide supervision. We have several examples here of what a family peer advocate would be doing within their day-to-day work. I'm not going to go over all of them in an effort to get through all the slides and for the discussion, so I'm just going to go through a few of them today. Some of the examples that we have: a family member is experiencing difficulties raising a child who is struggling behaviorally at home. The family receives family peer support services weekly in the home to practice strategies to support their child's positive behavior. That's that parent skill building. A grandmother has custody of her grandson that has behavioral concerns. Family peer support is meeting weekly with the grandmother to assist her with implementing parenting strategies recommended by her grandson's doctor, and to assist her in facilitating meetings with providers to ensure the shared decision-making. And that's that self-advocacy, efficacy, and empowerment. I think we'll skip the next one, and we'll go on to the WAN, which is, I believe, the next slide. Will you advance the slide, please? Okay, Juan. Juan is a 15-year-old, and he's about to be discharged from a residential program. Family Peer Support Services have been working with Juan's parents for the past 2 months to help them stay actively involved with Juan while he's in placement, obtain the support they need during home visits, and prepare for a smooth transition home. And below are some of the things that a family peer support worker, a family peer advocate, would be doing with Juan's family. They'd be helping Juan's family in understanding and implementing the state safety plan that was put in place by Juan, his parents, and Juan's service provider. They'd be making connections to recreational activities in the community that were a priority for Juan. And they'd be working with Juan's school to ensure, they'd be working with the parents to with Juan's school to ensure that the needed academic and behavioral supports are in place for Juan. And I think our last example is Connor and Haley. Connor and Haley, they were 7 years old. They were born prematurely. Both have serious asthma. Their mother, Lauren, is raising the children alone without any relatives nearby. She's missed numerous days at work and is worried about losing her job. The school keeps calling about her son's behavior. Lauren has been able to has always been able to handle everything, but she confides in her colleagues that things are starting to unravel. And her colleagues suggest that she call Family Peer Support, the Family Peer Support program. Within this scenario, there would be a referral to a Family Peer Support program. The Family Peer Advocate helps Lauren to work with the school district to start the process of obtaining evaluation for Connor. They arrange an appointment with the clinic as well. The FBA helps Lauren contact a free legal services clinic so she can work to obtain child support, which might allow her to cut back on her hours. They're also working on some strategies to support Connor's behavior at home. Over time, Lauren shared with the Family Peer Advocate that she was struggling with depression herself, and the FPA is helping Lauren take steps to really take care of herself. So those were just a few examples of the work and activities that a credentialed Family Peer Advocate would be doing with a family under Family Peer Support Services. I'm now going to turn it over to Meredith Ray Labatt, who is going to do an overview of youth peer support and training.
Thank you, Heather. I appreciate it. Hi, this is Meredith Ray Labatt, and I'm going to be talking about youth peer support in training. One of the things you'll notice is that there's a lot of similarities between these two services. We are really using a lot of our historical knowledge and understanding and experience with family peer support to really guide the development and the new creation of youth peer support as a Medicaid reimbursable service. In New York State, through the Office of Mental Health, we do have some experience with family peer support as a Medicaid reimbursable service in our waiver program. So it served as a wonderful, launch pad for really modeling a lot of what youth peer support is going to be because there was a credential on the family support side. So you'll see a lot of very similar elements to both these services. and there's a lot of crosswalk amongst them. In addition, you'll also see a lot of crosswalk between these services and the adult peer. So ideally, if a youth peer person is certified as a youth peer and then they age out, they can then become an adult peer on the other side. So by really aligning a lot of the work, we're hoping that there'll be seamlessness within the system as well, and there'll be a lot of consistency. So as you'll see, youth peer support and training also requires that the youth peer advocate be credentialed and that they be someone with lived experience. That's someone who has actually had personal experience in the child serving system, in mental health or foster care themselves. So they would be engaging in a number of activities to help train and support young people, to promote engagement and active participation in the youth treatment planning, really helping young people to know how to be an active member of their treatment process, and reinforcing skills learned through the treatment. So the services include things like skill building, coaching, self-advocacy, self-efficacy, empowerment, and community connections and natural supports, and we'll talk more about those next. So first, skill building. This is a common term that's used in a clinical ways, in support ways through rehabilitation or habilitation, but skill building for youth peer support and training is a little bit different because it's really using someone who's, again, been there themselves, who can guide a peer in helping to know what maybe works best for them, what has worked best with other young people who have similar challenges, and they help guide them with identifying skills that will work for them for coping, in managing their symptoms, for skills for wellness, how they can really balance their lives and engage themselves in activities that will help maybe mitigate some of the challenges that they're experiencing through things such as, let's say, yoga or joining a gym or some physical activities. Also skills for independence, what it means to really prepare for being an adolescent or a young adult in the world today, and also establishing goals in determining what's best for their future and how to get there. And of course, community living skills, how to negotiate your community, how to manage living in the community and being a part of a community. Next. Coaching. So youth peer advocates would also do things like coaching, which is guiding people on promoting wellness through modeling. Again, pulling from their own personal examples of themselves or of other peers or of other individuals in the field about what works well for overall health and wellness, the promotion of overall health and wellness, by providing mutual support, encouragement, guidance, partnering with the young person as they, of course, transition to different levels of care or into adulthood. Transitions are very challenging for anyone, including young people, and so guiding them through how to manage those transitions and how to prepare for those transitions is a large part of the coaching process that youth peers would engage young people in. Self-advocacy, self-efficacy, and empowerment. Obviously, you know, this is the very, very important aspects to all peer support services. It's that instead of giving a man a fish, it's teaching the man to fish, and helping someone really prepare for negotiating their lives independently and guiding them and supporting them in becoming self-sufficient. So certainly developing those skill sets, helping someone make independent choices, and playing an active role in their own treatment and their own life determination about where their goals are, what their goals are, and where their life is going. To facilitate use of formal and informal services, really understanding where to access resources and how to access resources in all aspects of life domains, and how to really do something as simple as how to find out what that is, and then how to make the phone call and how to ask the questions and how to really create those pathways to resources. And then, of course, obviously serve as an advocate, mentor, and facilitator for any challenges that might arise, and helping to model that problem solving that everybody has to negotiate in life. Okay, next. Community connections and natural supports. Those, of course, are really developing a network of information and support from others. Who are the people that you rely on? Who are the people that you go to? And if you are struggling finding those people, how you can create those yourself, really helping to create a network within your community and within your family or within your those people that you've chosen to be like family, and that's the natural supports that one has, and how that helps to support one's development of resiliency and work towards recovery. Next. So to be a youth peer advocate, you can be a youth peer advocate. Again, that's kind of, well, we'll talk about the level 1, level 2, but that's a full-fledged youth peer advocate. There's also a provisional youth peer advocate. That's someone who's beginning to work in the field that has the basis for becoming a full-fledged youth peer advocate, but has the provisional capacity to do so. We'll talk more about that later. And then, of course, there's the certified recovery peer advocate. So there's 3 types of kind of titles that are working titles that one could fall under in order to do this work. So to be a full-fledged youth peer advocate, to be eligible, you must be within the ages of 18 to 30. Again, it's based on lived experience, so the person would have to self-identify as a consumer of behavioral health services, special education services, or foster care. They have to have a high school diploma or an equivalent. And again, there's a waiver similar to that of the family side, depending on their level of experience and competencies in certain areas, so there's a competency waiver. Again, similar to the family peer advocate, there is going to be level 1 online components with a level 2 in-person training and a minimum of 3 consultation calls. Again, we're building this much on the same format and structure of the family peer structure. And the development of the family peer and youth peer structures are being built similarly with significant family and youth input on either end. So we're really, this is very ground up driven. And of course, 3 letters of reference attesting to the skill set of the youth peer advocate. Next. Okay. In order to complete your credentialing, you'd have to have done 600 hours of experience, hands-on experience, providing youth peer support within an 18-month period, 20 hours of continuing education every 2 years, so there's an ongoing educational component to this credential. Obviously, there's a knowledge of advocacy, which is part of the training and part of the hands-on experience and supervision. Familiarity with group development and facilitation. Again, this is covered in the training, but it's part of the supervision and part of the hands-on experience. And then, of course, the capacity to really use one's own lived experience to really assist in doing their jobs effectively. Okay. So the Youth Peer Advocate Provisional Credential, again, the same structure is available for family peers, is the same as the Youth Peer Advocate Credential with the exception of the following. So they've completed the level 1 requirement, they've had 2 letters of reference, and they've documented 600 hours of experience providing youth peer services. Now, this structure also is part of the application to CMS, and much of all of what we're talking about is contingent upon CMS approval, but this is what we've proposed and what's included in our SPA. So the state-approved YPA training, they have to complete state-approved trainings, and there will be, again mentioned earlier as far as level 1 and level 2 goes, there's an online training and there's in-person trainings, and they cover a multitude of topic areas such as these listed herein, which is the role, the peer mentoring and support process, how to facilitate groups, what's expected to be as a professional, youth peer, of course, your own self-care and support, same thing as any professionals for that, like vicarious traumatization. And then, of course, the level 1 and level 2 is part of that and covers that. So for the certified recovery peer advocate with a youth specialty, again, that's similar to the certified recovery peer advocate with a family specialty, but this obviously is a youth specialty. They too would have to be within the ages of 18 to 30. It's also, of course, required that there be lived experience as a family member impacted by youth substance abuse disorders. There's a requirement for a high school diploma or equivalency degree, 46 training hours in very similar content areas of advocacy, mentoring, education, recovery, wellness, and such, and ethical responsibility, which is similar to professional expectations. 1,000 hours of documented related work experience, 500 of which can be captured if they have a bachelor's degree or CASAC or CASAC-T. 25 hours of supervision. They have to pass the peer advocate exam. 2 letters of recommendation, 16 hours, of course, in the area of youth peer support, and 20 hours of continuing education earned every 2 years. So again, you'll see a lot of consistency, a lot of very strong similarities between the various peer advocate and peer support credentials. So the supervisor qualifications, again, somewhat similar to that of the family peer, but the individuals should have a minimum of 4 years providing the services, whether it be family peer or youth peer, and at least 1 year of which was a they were credentialed with access to clinical consultation, or a mental health professional with training and specific clinical consultation on a planned regular basis. So it could be either one of those 2 disciplines as proposed to CMS. Okay, I want to leave plenty of time for questions. So these are some examples of what a youth peer support would look like. So I'm actually just going to highlight one, and then I'm going to move on. So we'll do the first one. So Johnny is a high school junior, who is has an upcoming Committee on Special Education meeting, and he's invited his youth peer advocate to support him. So that means that Johnny likely has a mental health challenge or some sort of challenge that has gotten him to have a licensed professional recommend youth peer advocates. So he has youth peer advocates all approved, and that youth peer advocate is attending his CSE meeting with the parent and Johnny to support and assist him in verbalizing his goals and practice self-advocacy, self-empowerment, and what they've been working on for his plan. So the youth peer advocate is coaching him and mentoring him and helping him to be an active participant in his planning and in his goals around his special education. So that's a great example of youth peer support. So we're going to move on to similar guidelines. Okay. So while the services and the qualifications might differ, there are a variety of similar aspects to both family peer support and youth peer support which guide the structure of the service. And so those are the modality of the services, that is how the services are provided, group, individual, the settings where the services can be provided, admission and discharge criteria, what makes someone eligible to be admitted or receive these services, and what enables someone to have met their goals to be able to be discharged from receiving the services. The provider agency qualifications, what are recommended trainings for these disciplines, staff ratios, and billing codes. So there's a lot of similarities for both of these services. Okay. So modality of services, again, they must be face-to-face. They can be individual, provided to an individual, one-on-one, or there can be groups. The family groups are composed of 2 or more families that can't exceed more than 6 families, so it's no more than 12 individuals. And for young youth groups, composed of 2 or more families cannot exceed 12 individuals total. So again, considering some flexibility within the 2. So components not directed exclusively toward the benefit of the Medicaid eligible child are not eligible for Medicaid reimbursement. So the important thing is that that in order for the groups to be and the individuals to be reimbursable through Medicaid, the goals are specific to the Medicaid child. Is that what that says? Okay, it's standard Medicaid lingo, process anyway. So settings and caseload side. So settings are quite broad, really. Services can occur in a variety of settings. They can be community locations, wherever the child and family lives, works, attends school, engages in services. So it's really at the at the needs of the child and family, at the request of the child and family. However, it's best that the child and family can be engaged and they can be located. So sometimes you got to go where the services are, where the people are, right? Caseload size, this is really based on the needs of the child and families with an emphasis on successful outcomes. So of course, there is some discretion here, but the intention is that the caseload size is based on the needs of the child and family and the capacity of the worker to provide the services, manage the needs of the family, and do the required documentation and all other associated Medicaid required activities for that child and family as well. So caseloads are flexible, but it really is contingent upon the satisfaction and outcomes of the family. Admissions. So in order to be admitted into the service, again, that's kind of a strange term, but in order to receive the service must be identified or developed, meaning that identified if there's a licensed practitioner that sees that this person requires the service, so it could be, let's say, a pediatrician, or if it's developed, meaning that the child and family is already engaged in a service with a licensed practitioner. So it can be identified or developed by a licensed practitioner of the healing arts. The services are really intended to maintain the child in the community and enable them and support them in remaining in the community. It's directed at developing skills or achieving specific outcomes, and the amount, duration, and scope of the service aligns with the unique needs of the family. So you can see there's a lot of alignment here between medical necessity and what enables a child or family to be admitted into the service. Next. For discharge, obviously, this is very commiserate with much of the discharge criteria for any service, particularly in mental health or substance use, is that you've achieved your goals and your outcomes, and that you've met them, and that everything's wonderful, and so at this point, the child or family can be discharged. The user family has shown significant progress in their ability to expand their skills and learn strategies and meet their goals. And they've been involved in the discharge process. So they, again, the self-efficacy, the self-advocacy and the empowerment has really taken hold, and they feel as though they are satisfied and capable of being carrying on independently. So reevaluation or plan review, again, as with every Medicaid reimbursable service, a reevaluation should occur to assess whether the child and family are still in need of the service. They are to review their goals, and they are to see whether or not there's been a reduction in the challenges that brought them to be admitted into the services. And if they're still to be maintained in the service, then they should be revising the goals to make sure that they are measurable and that they're consistent with what the family and child needs and what the service can provide. Okay. So provider agency qualifications. These are agencies that would be capable of providing these services. They are any child-serving agency that is licensed, certified, approved or designated by OMH, DOH, OASIS, OCFS, DOH, OASIS, OCFS, and OMH. There's going to be more information to come on this as we Angela highlighted earlier in our discussion the designation process. So there's going to be more information to come on this in the future, hopefully the end of the summer, I think you mentioned. So to be a Medicaid agency and to bill for these Medicaid services, they have to adhere to Medicaid requirements and follow all of these very standard, consistent type expectations for a Medicaid reimbursable agency. Okay, all right, let's move on. We have recommended some service-specific trainings. They are such things as domestic violence, signs and intervention, motivational interview, personal safety in the community. Anytime there's a service where the worker is going into the community, into the home, there's a hope that they would be trained on personal safety in the community. And there's an outlining of available training resources listed below. Okay. So, here, as I said a moment ago, the provider designation criteria process is going to be out shortly. We're working on that. There'll be more information to come. The SPA service documentation requirements will also be coming. We're working on that. Utilization management process and such. The family peer support and youth peer support trainings on things such as billing, medical necessity, and other limitations is also forthcoming. We are working on really drilling down to the specifics of those things. So once those are finalized, they will be incorporated into the SPA provider manual, and we will be sharing that widely. Now for training and resources, I'm going to turn it over back to CTAC. MCTAC. Is that one of the TACs? Thank you.
Yes, thank you. Thank you so much. Training and resources, next slide, please. So the SPA training series schedule goes as follows. The next one is going to be Thursday, the 21st, Community Psychiatric Supports and Treatment, and then the following Thursday, July 28th, Crisis Intervention. There will be state-led trainings on the Children and Adolescents Needs and Strengths, Cairns, New York. In Albany, let's see. There's one going on that happened yesterday in New York City, and there will be another one in New York City on August 29th and 30th, and then in Rochester on August 18th and 19th. Next. So the SPA training plan, I'm not going to go through it. You can read it. Next slide. Next slide, thank you. For resources and information, it's all there. You can read that. Next. And so I think we have a few minutes for questions and discussions, and if you the questions are not answered, you can contact mctac.info@nyu.edu, and the questions are usually you usually get a response within 1 business day or less. And we appreciate your interest and your patience. And again, our website is www.mctac.org. If you would like to view past trainings or sign up for updates and event announcements and access resources. So I'll turn it over to the questions.
Okay, thank you. This is Angela Keller from the Office of Mental Health. I think we only have a time for about 2 or 3 questions. One of the questions that came in was regarding really a question about timeline, that we are looking at releasing the SPA provider designation application and completing the designation process before CMS will have approved the SPA and certainly before implementation occurs. So we believe that CMS will approve the SPA. We had sent them the SPA in draft last summer and had some dialogue and made some revisions based on their suggestions. We have also kept an eye on some other states' state plan amendments for very similar services, and been fortunate to be able to know the questions that are being asked, so we feel well prepared to respond to CMS's questions once we get to that point. And additionally, there are over a dozen states that have had state plan amendments with these exact services already approved by CMS. So we really are very confident that that's going to happen and enable us to start in January as we are planning. A question has come in regarding, can a provider provide care management and SPA services for the same individual? Yes, you may. SPA services do not fall under conflict-free or conflict of interest rules that exist for home and community-based services waiver, so there is not an issue for one agency to be both the care manager and provider of SPA services. I'm going to turn it over to Meredith and Heather to pick some additional questions to respond to more specifically around the credentialing.
Okay. So there's a question about whether or not the youth peer training is now available online. No, the youth peer training is not, the credential The credentialing training is not available yet for youth peers. That is still being developed. There is a youth peer training that we're using for the one that will be used for the credential is not yet developed. We'll keep you informed of that. There was also a question in regards to if a young person under the age of 30 is a peer specialist, can they become a youth peer advocate? It's likely that having provided peer support services will count towards qualifying the person to be a youth peer. It might be, depending on who they've worked with or what their experience is, they still might have to take the training, but their hours of experience and work would likely count towards the credential. Those types of scenarios would be determined in the application and based on the person's experience in the field. Heather, can you see the questions?
Yeah, there's a few of them that I can attempt to answer. There was a question: is it 18 or 24 months for the provisional status? Because it was written two different ways in the PowerPoint presentation. It is 18 months for the provisional. Someone can have a provisional credential and bill. The reason why we have added that level 1 provisional is so people can obtain those $600 for the youth peer and the $1,000 for the family peer advocate, because we realize many folks are coming into the field without that experience. So we want people to get a baseline of training and then be able to bill, but then they would have to get that full credential within 18 months. Let's see. Who will monitor the required 20 hours of continuing education for maintaining the certification or credential? That will be the credentialing body that will be managing those 20 hours of continuing ed. And also, I think we will also be leaving that kind of up to the family peer advocates and the youth peer advocates to keep track of their own hours, but we will have the credentialing entity actually be the one that holds that. At what age do youth peer advocates age out? Right now we are proposing to CMS, and Angela and Meredith, correct me if I'm wrong, it's 18 to 30. We've pushed it to 30. So at age 30, they would no longer be a youth advocate. Let's see.
Okay, well, it's 2 o'clock right now, and I know many people, and including ourselves, have other meetings. So I think that's all we have time for today. We can look at what other additional answers we have for folks that we didn't cover today, and we can be sure to get some answers for you and send them out via the listserv. So I think that'll be all for today. Thank you, everyone, so much for participating.
Thank you, everybody.
Thank you.